sometimes to come back, and I'd like to thank the organizing committee for inviting me. It's always a dear place for me to be in. I think this talk dovetails nicely with the previous talk in the sense that, I just want to put my timer so I will get the time right. In the sense that we're speaking about the same topic. Although he was speaking about staff, I'm speaking about patient mainly, but I will speak about staff later on at the end. Like you do, before I wanted to prepare this talk, I spoke to a couple of my colleagues back at work, telling them about the title of my topic. And that was their reaction. They really fell on their back laughing. They thought, gosh, what an unimportant topic. You should be going and speaking about artificial intelligence, AMH, endometriosis, adenomyosis. These are the things that we like to hear about in infertility. Emotional stress, come on, man up and tell your patient just to carry on trying. Well, I disagreed with them, and I suggested to them that this is probably, for doctors and embryologists and people working in the field, the most important topic in the conference. And if you don't deal with it, it poses, to use a commonly used word, an existential threat. يعني بالعربي تهديد وجودي، بيهدد وجودك. It will threaten your existence as an IVF practice if you don't deal with it. And I explained to them that although we like to see it, not most of our patients, only a few of our patients will have the smile on the mother of Louise Brown here when she was born and put in her hand, or Michelle Obama when she was telling the world that her two lovely daughters have come from IVF, or Amal, the wife of George Clooney, that's reputed that her twins have come from IVF. In fact, the majority of our patients, as you and I know very well, in any individual cycle, will not succeed. Even in the young ages, the majority of individual embryos will not implant. Why? Well, this is for another story. This is how nature intended it to be. We as human beings have very poor fertility. How do we fill the world with people, with babies? We make up for it by repeated attempts. So your cat can only get pregnant once a year, but you can get pregnant 12 times a year. And that's how our fertility is made up. But when we come for IVF, we measure it cycle by cycle. So not surprisingly, we have low fertility rate. And it has been estimated that if you look at live birth, even in a country as advanced and as well regulated as the UK, you're going to get no more than 50% people with a live birth to take home after 6 repeated attempts. Gosh, 6 times. Although if you look at the figures in other lectures telling you they have a 90 and 80 and 70%, you'll think after 6 times they have 5.5 babies. But you and I know that that doesn't happen. What is said in the lectures is different from what happens in the labs. And so much so that some patients, as you and I know, will tell you, gosh, I've done IVF once or twice. I've spent so much money, I've spent so much of my time and my emotions and my effort. I wish IVF had never been invented, as this patient reported to the BBC in the past. So I put it to you that you need to know how to deal with your stressed patients if they have failed IVF, because it is very distressing to have treatment. It's even more distressing to have infertility treatment. And the worst distress is those who have failed IVF treatment. That is said, that is very obvious. And it has been shown in studies that looked at the reason for discontinuation. Discontinuation here means that a patient has come to your clinic, they had their first treatment, and then they decided not to come back for treatment. The commonest reason after a failed IVF is psychological stress. 69% of patients will not come back to you, not because they cannot afford you, or not because they don't like you or don't like your staff or can't find a place to park, but because they're emotionally distressed. Surprisingly, also 25% of couples that don't come for a second baby, having had their first baby in your clinic, will say that they were so much emotionally distressed during the treatment that they don't want to come and think of another baby. And you and I have seen these people who've had the first baby, and then you will say to them, when are you coming for the second baby? Because people like to have more than one baby. They say, no, gosh, it was so stressful. Gosh, but it worked for you. Yes, but it still was so stressful. So failed IVF is very demanding both physically, financially, and emotionally. And it's very distressing as well. Therefore, if you know how to manage these patients well, your patients will come again and again and again to you. And if you don't know how to manage them, your clinic will not be as successful as it could have been. Therefore, I put it to you that the AMH of this world will disappear as the day 2 FSH has disappeared. The new methods that we have new today, tomorrow will not be longer new. But a human being, from the date of Adam and Eve till now, they will be stressed when they don't get what they want. Gosh, sometimes we're stressed when we get what we want, as we know, because it's not as nice as we thought it would be. And you need to know how to manage the stress of your patients and your staff, and we'll come to that, in order to become a successful IVF unit and practitioner. We know that many patients will experience subclinical levels of distress, anxiety, and depressive symptoms following a failed cycle. Subclinical levels mean it doesn't affect your ability to live your life. And generally speaking, in psychology, they say if you feel down for a couple of weeks after a bad event, failed an exam, failed a driving test, left your partner, whatever you want to say it, 2 weeks is acceptable, normal. If it carries on longer than that and it's affecting your day-to-day work and life, then it's called a clinical depression. And that was my question to the previous speaker. Do you feel down? Everyone feels. If you ask any of us, did you feel down at any time today? Yes, we felt down. I couldn't get to the queue to get my coffee. I couldn't find a seat to sit. Does mean that the EFSS meeting causes the stress? No, but it's normal to be stressed in life. وَخَلَقْنَا الْإِنسَانَ فِي كَبَدٍ. That is normal in life, okay? We're speaking about clinical distress and depression versus non-clinical. And although the majority of human beings and patients are well adjusted and resilient, some will experience more serious distress, and in studies it has been shown that it may last for a long time and be one of the causes of their marriage breakdown. Therefore, it's very important to recognize that feeling down is normal, but feeling clinically depressed and severely anxious in the way that it affects your life is something that needs to be dealt with. On the other hand, as far as the staff is concerned, and I don't look at the workload, what the previous speaker, and maybe it's unfair to speak when he's not here, but I'm speaking in his favor, working 7 days a week or working 2 jobs instead of 1 should be illegal according to the laws of labor, قوانين العمل, as we say in Arabic. So that is illegal. That is not, should not be done and should not be tested. Is it okay or not? It is not okay. Just like pilots, I came in a lovely Egypt Air flight yesterday. I was sure that the pilots flying that flight were not working above the legal hours allowed for pilots. And that should be in all of us. Now, if your employer decides to be illegal in their practice and the country you work in allows it, that's a different story. That's not something to be studied, if you see what I mean. We're beyond that stage in humanity, so to speak. So giving bad news, as we do in IVF, and dealing with people who are distressed, whether nurses, embryologists, receptionists, or doctors, is very distressing for the treating staff. So how do we deal with it? How do we manage it? First of all, how do we manage a failed IVF cycle? I think it is important, and I think all of you do that. I say this to remind myself and remind you. We should have senior staff dealing with patients who fail IVF. I once worked in a job, I won't say where the junior used to be sent to the failed IVF clinic to take the blame, and the boss used to go to the successful cycles clinic to take the credit. That was horrible, because anyone can congratulate the patient who has got pregnant and tell her what to carry on with luteal support if that's what's necessary, and see you in 2 weeks for a scan. But some who had failed IVF need special clinical requirements that come with seniority, what to do next, reviewing the cycle, and needs special psychological or emotional care. So a senior member of staff should meet the couple, empathize with them. Empathize with them doesn't mean cry with them, but tell them that you understand where they're coming from. You understand that they have spent a lot of time, a lot of effort. We told them that their embryos were beautiful, but still they didn't get pregnant. You must be very disappointed, I say to you. And if some of them says, no, I'm not, I say, gosh, I would be if I were you, because you've done everything you could, and you still didn't get what you want. That really is disappointed. Let's see what happened. And then you get the notes out and review the cycle and provide brief and sufficient information to tell them what happened. Even if you can say, we don't know why you didn't get pregnant, which is the most of the time, the most of the cases, and facilitate future decision making. And you have to remember that they have just had a shock. As one of my patients said, someone has come and hit me on the head with a stick. And واحد خبطه على دماغه زي, as we say in Arabic. They will not remember anything of what you've said to them. So you must give them clear written, and I suggest printed, because our handwriting goes as an example of bad handwriting. Clear printed summary of what you've discussed with them, because that's the only way when they sit at home later on and they want to discuss it, they will remember it. But if you just rely on them remembering what you tell them, you're very optimistic. And also speak about the future, even if they don't want to discuss it. And when you speak about the future, give them realistic chances of what is going to happen to them. So if a 25-year-old comes and doesn't get pregnant after the transfer of good quality embryos, then her chances of getting pregnant next time is X%. But if a 42-year-old lady comes and produces 2 poor quality oocytes and only 1 poor quality embryo and she didn't get pregnant, you tell her that the chances of her getting pregnant next time is in the order of 2 to 3% live birth. You have to be realistic. Avoid over-promising to make the person in front of you feels better. It's very bad. And of course, it should be that we have a qualified and trained counselor in every clinic. In fact, in the UK, for example, where I practiced for over 20 years, you are not allowed to open an IVF clinic unless you have a counselor as a member of staff. In the Arab world, that doesn't work in many places. In Jordan, when I went back about 15 years ago, I tried to have that, all the patients resisting seeing a counselor. We think in our culture that seeing a counselor, we used to think 15 years ago, I didn't try it again, you must be crazy. While it's not the case. So we must remove the stigma that people have about psychological counseling. And that's a job for the whole of society, and we'll contribute to it. There are patients that are more likely to be severely distressed, such as those with previous mental illness, those with previous postnatal depression, those who show you that they are extremely worried when they come to you. And with experience, you'll be able to differentiate. You have to give them realistic chances of expectations. So don't tell a 45-year-old that, 90% chance of getting pregnant. A, this is a lie. And B, it will make her expectations so high that her drop from the high place you've put her in will be so severe, she will definitely get depressed. And also, don't put the burden on the female only. If you want to discuss difficult decisions, like do we proceed with the cycle or not, do we transfer how many embryos, do your best to convince them to have both partners present, even if you insist. He has to come to give you a sample, so he must come and discuss these things with you. I know different cultures are different and different places are different, but this should be where we should aim. And also something to help you manage your stress, and that's something helped me massively, is whenever I come to a difficult decision, I share it with the patient. For example, you have poor response, 1 or 2 follicles only in someone who unexpectedly underresponded, and you're wondering, do you carry on with the IVF or do you stop and restart again? And neither decision is an easy one. The first one will involve a lot of cost, the second one will involve a lot of disappointment. And what about if you stop and carry on next time with a higher dose and she still doesn't respond at all or produce less? So that decision should never be taken by yourself alone. You should share it with the patient, explain the pros and the cons to them, and then tell them make the decision. And finally, Don't blame patients or staff or laboratory for failure unless there's a clear-cut evidence. Don't offer useless add-ons, as a lot of people do, hysteroscopy, scratching, heparin, or everything else, and don't promise what you cannot deliver. And as far as your staff, tell them that your patient may be very stressed, train them how to deal with it, identify that your staff can go also extremely stressed, and protect them against the hustle that your colleagues may do that, as we have seen from the previous case. Thank you for your attention, and I wish you all the best.